For our second club meeting in the field of medicine, we are providing today an up-to-date meeting on the inflammatory bowel disease, and we are honored to host an expert panel and speakers. We'll start by Professor Sebastian, then Professor Maha Saballah, then Professor Hisham al-Makhzangi. But at first, let me introduce you to us. We are the RCP Egypt. We are a non-profit, internationally affiliated body representing the Royal College of Physicians in London. And I need to make this clear. We are not related to the MRCP. We are related to the Royal College of Physicians Fellowship, Training, and Exchange. What's our vision? Our vision aligns with the global vision of the Royal College of Physicians, which is to advance health and healthcare in Egypt. What's the mission? Our mission will be the initiation, propagation, and development of RCP-led programs for physicians, providing support to fulfill their unending potential. The RCP aims to provide such support to aspiring established physicians of all ages to work relentlessly towards improving the standards of health and healthcare. And on behalf of the Royal College of Physicians and as a representative of the Royal College of Physicians London, I welcome you to the start of our meeting. Introduce Professor Dr. Hisham al-Makhzangi to give a short introduction to the CV of our honorable speakers. Thank you.
Hello, good afternoon, everybody. We're going to give most of the presentations today in English, courtesy of our dear Professor Sebastian, who will be attending with us. Hopefully his time will permit him to attend the entire function. Professor Shaji Sebastian is a consultant gastroenterologist in Hull University Teaching Hospitals. He is the clinical lead of IPD in Hull University Teaching Hospitals, and he leads an integrated IPD unit called IPD Hull for clinical and research purposes. Dr. Hull is world-renowned. He is the current chair of the Clinical Research Committee, or Clinicom, in the ECHO Foundation, the European Crohn's and Colitis Foundation. Dr. Sebastian has published literally hundreds of papers, mostly in the field of IPD. I've counted 300, but probably by now he published some more. He has an H index of almost 40, which is remarkable. Now, he is also the chair of the British Society of Gastroenterology Research Committee since 2021, September of 2021, and he is also an executive committee member, and he is also a current member of the IPD CRG, and also he is the lead in the IPD subgroup of the BSG Artificial Intelligence Task Force. So without any further delays, I will ask Dr. Sebastian to start his presentation. He's addressing a very interesting subject of perianal fistulization in Crohn's disease. It's a subject of immense importance. The patients are really difficult to treat, and sometimes we're baffled what to do next. And then the patient fails to respond to a line, then he fails to respond to another line. You try to involve the surgeons won't want to be involved at all. So without any further delay, Professor Sebastian, the floor is yours.
Professor Hisham, this evening, and Professor Reem for the kind invitation to be present at this meeting. I do believe that meetings such as this, under the auspices of your college, is hugely beneficial, and well done for organizing this meeting. So as Professor Hisham said, I'm a IBD clinician based in the UK, and today I'm going to talk briefly about the management of Crohn's disease, perianal fistula. Before we talk about fistula, perianal Crohn's disease can have a variety of phases. You can see some of these here. On the top left corner is what you are seeing, perianal skin tags. Now, not all patients with skin tags can have CD, but this is a very common manifestation of Crohn's disease. So you can also develop ulcers, as in the picture B, or it could be, fissures, which are extremely painful. But the most dreaded of these is the perianal abscess and fistula. And because, as Professor Hesham mentioned, this is a difficult condition to treat, this evening we are going to focus on approach to the perianal fistula alone. So let's go back to some basics. Sort of what is a perianal fistula? These are essentially abnormal tracts or tunnels which are connecting the rectum or the anal canal with the perianal skin. So by definition, you do have an internal opening, then there is a fistula tract which is sort of wiggling around and then coming out externally as the external opening. So why should we care about perianal fistula in Crohn's disease? First of all, they are very common, and this is one of the very early studies from Mayo Clinic way back in 2002, which looked at the Minnesota cohort, and they looked at over a period of 20 years, roughly about 20% of patients had perianal fistula, so 26% after 20 years. So it is about 1/5 of patients, at least in those earlier studies. The same group has now published an update on the epidemiology, and there is actually somewhat a reduction in the cumulative incidence of perianal fistula to about 23% after 20 years of overall fistulas that included rectovaginal as well, and perianal fistulas about 16%. So there has been some reduction, and the reduction appears to have happened based upon at least this study when they compared those who had Crohn's disease diagnosed before the age of 1998, and then after 1998 you can see there is a reduction in fistula. Now what has happened in 1998, that is the time when biologics, particularly the advent of infliximab or Remicade, came into practice around that time. So at least the postulation or hypothesis is that perhaps the early management of Crohn's disease and early use of biologics may have reduced some of the incident fistulas in existing Crohn's disease patients. Now, we have looked at it in a large study ongoing in the UK, and this seems to bear fruit, although that is not yet published. So another reason why we need to be interested in fistula is that they are very morbid condition and they really can impact the patient. So here is a patient who has a complex perianal fistula. You can see all this external opening, and probably you can imagine that underneath these lumps or the pimples there are probably abscesses underneath the skin, which can be very painful, particularly in the presence of abscesses. And then when these abscesses are discharging, you can form the tracts, which can drain pus or fecal matter, and this can be pretty distressing for the patient. So that way, it does have impact on patients in a significant way. So we just talked about the impact. It's not just the pain or the chronic drainage or the irritation, or indeed some cases sepsis due to infection in that region, which may impact patients. It can also impact their daily lives in relation to productivity. So, for example, they may miss their schooling or work. Some of them may not be able to sit comfortably on a chair. There are a number of studies, including some of our own, which has shown that it has significant impact on mental health as well as psychosexual health. So it is indeed, I'm trying to paint a picture that Crohn's disease perianal fistula is one of the most disastrous phenotypes of Crohn's disease. So hence, it's very important that whatever treatment we are offering to patients with Crohn's disease perianal fistula, we need to think about the quality of life and what patient accepts as treatment, and hence the engagement with the patient at every step of management is essential, and I'll come back to this theme later. Another reason why perianal fistulas are of particular interest to me is that despite all the advances in the rest of the management approaches to Crohn's disease, our fistula management hasn't made huge strides. So this is one of the studies which has shown that even if in patients who had one fistula cleared, there may be a recurrence of fistula, or with some of them, 33% of them having 2 or more fistula episodes. So this is a challenging problem. So when we talk about the management goals in perianal fistula, we have to have a number of goals. Some of them are short term, and this includes mainly reduction in symptoms and clearance of sepsis, that is abscess drainage. And then there are long-term goals which essentially are aimed at improving the quality of life, preserving continence, and if possible and where possible, avoidance of proctectomy with stoma. So it's important that these short and long-term goals are discussed with patients, and what patients prefer in terms of their goals and their different stages of life is taken into consideration. So before we go into management, it is or treatment, it's important how we evaluate a perianal fistula. We need to adequately evaluate this before we go into the specifics of treatment. So when we are assessing patients, we can look out externally, and examine. And here you can see there is clearly an abscess and abnormality there. But what we are seeing externally may be just the tip of the iceberg. It doesn't tell us what is happening underneath the surface of the skin. You may have a single fistula like what is shown on the top picture there, or you can have a complex network of fistulae within arising from that tract, and hence we need to evaluate the fistula and map out the fistula before starting on our management approach. On this regard, the anatomy of the fistula is important. I'll walk through this for the benefit of our junior fellows, that essentially fistulas are classified in the broad sense. This has been around for over 30 years or so now, this classification. There is a superficial fistula which has got no involvement of the sphincter. Then there is the B, which is what is called the intersphincteric fistula. So your fistula is between the internal sphincter and the external sphincter, those two muscles. That is where the intersphincteric fistula. Then you can have fistula which cuts across both the internal and external sphincters, what is called the transsphincteric fistula. And in rare occasions, the fistula may be actually suprasphincteric or indeed extrasphincteric, going above both the sphincter levels and then branching out and then forming a big abscess in your buttocks region. So understanding the anatomy of the tract in relation to your sphincter muscles is important, not least for the reasons of understanding what will be the impact on patients' continence. So a number of years ago, AGA came up with this classification of simple fistula and complex fistula. And I'll show you something what we have done more recently in relation to classification, but this is the most common and well accepted classification as we have right now. So essentially, simple fistula is a low fistula. So usually it's a low intersphincteric fistula. They usually have a single external opening. More often than not, they may not be associated with a perianal abscess. You may just find an induration and obviously the opening. They do not connect to vagina or the bladder, and they are not associated with rectal stenosis or proctitis. On the other hand, complex fistulas belong to the rest of those pictures which I showed you, including the high intersphincteric and transphincteric fistula. They can have several external openings and are often associated with perianal abscess, and some of them may indeed have rectovaginal or rectovesical fistula. A number of them may be associated with anal stricturing or rectal stenosis, and proctitis may often be associated and thus have some prognostic significance. So let me talk you through one of the cases which we saw. This is a 26-year-old bank employee who presented to a nearby hospital with perianal abscess roughly 2 months ago. And as often is the case, these patients quite often end up in your emergency department and was seen by general surgeons. Initially was not thought to have a significant enough abscess to drain and was discharged on antibiotics and codeine. 6 months later, the wound was not healing, so the same general surgeon did some incision and drainage, and that did not heal fully. A good 9 months later, had a further recurrence of abscess. And on this occasion, when we took the history, he mentioned that he always had what was labeled as irritable bowel syndrome, and the wound which was there at his bottom never fully healed. However, he was very embarrassed about that and did not disclose it to his general practitioner or indeed to his family, and he was not socializing much, so it was affecting his day-to-day life. And indeed, he felt that it did affect him in such a way that his relationship at that time had broken down. So on examination, he had one draining fistula and he had induration. He did have some tenderness, but no clear suggestion clinically of abscess, and there was nothing else to find on examination. So why I'm showing you that case is to primarily to highlight this thing. When should you be suspecting an underlying Crohn's disease when patients with perianal abscess? And these are some of the features which I commonly tell my residents, that if there is a history of among the patient with, or a family history indeed consistent with inflammatory bowel disease, if there is early recurrent abscesses, inadequate secondary healing, and if you do have access to the original examination under anesthesia report, if there is any proctitis, if there are perianal skin tags, then these should alert you to look for evidence of underlying Crohn's disease. Now, once we do have such a patient, what definitive tests need to be done? This is in no particular order, but I think all these patients should have an MRI of pelvis, examination under anesthesia, and an ileocolonoscopy. So let's look at the MRI, and this is a typical representative MRI scan of the pelvis in a patient with perianal fistula, and you can see from the arrows which you can see there is actually a transsphincteric fistula which is going across the sphincter, and there is a clear abscess cavity in the middle. So the first step in that evaluation, and this is also part of the treatment process, is examining this patient under anesthesia, and if necessary, having a ketone, which is a thread to facilitate the drainage of any undrained sepsis within the fistular tract. So that should be the first step in that evaluation. Often patients are given antibiotics at that stage, and the type of ketone what is put in these situations vary. Our preference is to have just a loose draining ketone, which is much more comfortable to the patient. There is controversy in the literature, and I will touch on this little bit later, how long will you keep the ketone, and there are aspects to consider such as the epithelialization of the tract. And then there is this vexing question if and when to remove ketone once you put in one in the first place. So sorry for the gory picture there, but this is how, that particular patient picture which I showed earlier required multiple abscesses which were drained and ketones were placed. And despite the previous label of irritable bowel syndrome, this patient did have some involvement of the rectum, not very significant. You can see on the left picture, solitary aphthoid ulceration in the rectum. But when we went to the ileum, you can see the large, typical appearance of Crohn's disease affecting the ileum. So this patient does indeed have Crohn's disease. So this is roughly my diagnostic algorithm when patients present with fistula. If almost all of them require all three modalities, and there is some thought in places where there is expertise, and I'm really interested to hear from in the next lecture about the use of ultrasound. But there is some literature around endoanal ultrasound as well. But at least in the UK, we do MRI, ileocolonoscopy, and examination under anesthesia. Then let's dive into the treatment. So there are a number of treatments which we may consider, and I've deliberately put steroids with a question mark, and I'll come back to that later. But otherwise, conventional treatment of perianal fistula, as it stands now, still remains what we call as the multimodal therapy, which means combined medical and surgical therapy. And the combined medical therapy is combination of anti-TNFs and antiopurines or methotrexate. However, the sobering fact as of now is that less than 20% of our perianal fistula patients truly heal and close fistula. Hence the reason we need to continue to research and look for options for these patients with troublesome presentations. And when we looked at our own data on multimodal therapy, this did result in fistula healing in a higher proportion of patients, and we found a number of variables which won't go into detail in the interest of time, which is associated with fistula healing, but this is being now looked at in a prospective cohort in the UK. What about the benefit of anti-TNF? This is a meta-analysis, admittedly many years old, which looked at the improvement and closure of fistula with anti-TNFs alone. And on the face of it, it looks there is almost one combined odds ratio of 1.83 to closure of fistula, but these are actually short-term data. But when you look at long-term, this doesn't really is persistent in many patients, particularly those with complex fistula. And there are a number of potential reasons for it, and I'll come to some of this later. And first of all is about the dose of infliximab. Okay. Now it's been shown in a number of studies, admittedly observational data rather than randomized control trial data. The randomized control trial currently is just initiated to answer this question. But this is one of the observational studies from Israel originally, which looked at whether the infliximab trough level, this is at maintenance stage, does it impact on fistula healing? And what they were nicely able to show that a level between 10 to 20 appears to have higher rate of fistula healing as well as fistula closure, up to 42%, and any more than that, there was only marginal improvement. So tend to aim for higher trough levels in patients with perianal fistula. When we looked at our own data, we've also found that compared to those patients who had lower trough levels, higher trough levels was associated with a higher proportion of closed fistulas. What about the concomitant immunomodulatory therapy? I should say there is no Sonic-like study for combination therapy in perianal Crohn's disease, but in my opinion, these are patients who have a challenging phenotype of Crohn's disease, and we perhaps want to throw the kitchen sink at them, i.e. both thiopurines as well as anti-TNF, safety permitting. And this is the approach which was adopted by the Toronto consensus, which said that in patients with Crohn's disease, combined thiopurine over monotherapy is better, admittedly a conditioned recommendation with low quality evidence. So I tend to use both infliximab and thiopurines together. What about antibiotics? So now these are two nice studies. Actually, both came from Europe. The first one was the ADAFI trial, which looked at adalimumab along with ciprofloxacin compared to adalimumab with placebo alone. And they were able to demonstrate at week 12 and a statistically significant reduction in fistula activity and fistula drainage, although this was not really persistent at week 24. Another study from Amsterdam, again, this time looked at infliximab and ciprofloxacin. Again, that seems to have not shown statistically significant difference in adding antibiotics to infliximab. So the literature here is somewhat mixed. I should say we continue to practice based upon the ADAFI trial. We tend to give antibiotics for the first 4 weeks, whether along with infliximab, and whether that is due to the improved pharmacokinetics of infliximab as a result of concomitant use of ciprofloxacin or clearance of sepsis. It is something for debate. I said I will briefly mention about steroids. I would say this is one situation I clearly would caution against use of steroids, and this has now been replicated in one of our own studies, that while we use often in luminal Crohn's disease, in perianal fistulizing disease, many studies have shown worse outcomes in fistula activity, and hence my practice is to avoid steroids in those patients who have perianal fistula. Now, once we start on anti-TNF, particularly in some parts of the world, it may well be mandated to consider anti-TNF withdrawal. But what the data is showing us very clearly, at least in this phenotype of Crohn's disease, was majority, up to 78% of them relapse following cessation of anti-TNF. So it's not my usual practice to recommend anti-TNF withdrawal in those with perianal fistula. Another aspect to consider is about what I briefly alluded to earlier, which is about the aspect of ketone removal. Now, this is one study which looked at that. This is a retrospective study and observational study, so all the caveats and health warnings associated with that. But what it has shown that if you actually remove the ketone between less than 2.5 months after starting anti-TNF, there is a better chance of complete fistula closure. Now, that is somewhat intuitive because delayed removal of a foreign body in a tract may reduce the risk of reepithelialization. But of course, this needs to be balanced against the risk of development of recurrent abscess. So the jury is out on this, but our practice is that after 3 doses of infliximab, we discuss with the patient of the feasibility of removal of ketone, which is done by the nurses when they attend for their third infusion, and are given direct access to attend should there be any recurrence of abscess. Indeed, we did look at this in one of our previous studies, and ketone removal was associated with avoiding the need for repeat surgery. So this picture is somewhat difficult to read, but it essentially talks through a treatment algorithm of Crohn's disease perianal fistula. This was published by one of my friends and colleagues, Christina Gekse from Amsterdam, which was published in Gut. A simplified version of it, what we follow in our service is as shown here. So when they present within the first 7 days, we get an MRI examination under anesthesia, ketone and screening. We already start them on some antibiotics, and once the surgeon informs that examination of under anesthesia and drainage of sepsis is successful, within the following week we start them on anti-TNFs along with immunomodulators, but continue ciprofloxacin as per the Adobe trial protocol for 4 weeks. Then when they come up for their 3rd dose, we remove the ketone, we measure their drug levels at week 6, and if it is less than 25, that I'm talking about, this here is week 6 level, we give an extra dose at week 10, and then after that we are dose optimized anti-TNF and immunomodulators to maintain a level between 10 to 15, and we reassess the response at 6 months. Now, this has not been formally evaluated in a randomized controlled trial fashion, but I know there are 2 trials ongoing, including one of ours in the United Kingdom. Now, no talk on perianal fistula goes without mentioning surgical, and there are a number of surgical techniques which have been proposed. Many of them haven't really seen the light of the day, I should say, but the ones which I do still see as having some promise but remain still investigational and in expert hands are these 4. Lift or the ligation of the intersphincteric fistula tract, then fistula tract closure or the FILAC procedure using or video assisted anal fistula treatment. So these are available and are going to be again evaluated in one of the health technology assessment trials in the United Kingdom. But I'll briefly mention about stem cells because this is the flavor of the month, if you like. You all heard of the ADMIRE CD trial looking at mesenchymal stem cells. On the face value, it suggests that they had a very good improvement, about to 49.5% of patients meeting their primary endpoint. That means actually absence of any draining fistula, 50% reduction in draining fistula, and absence of any abscesses, and in fact that response being sustained at week 52. But look at the placebo response rate. So even for an IBD trial, it is staggering. The placebo response rate was nearly 35% on both situations, and this really begs the question: was it really the very strict protocol of curettage of the fistula is actually driving? Yes, stem cells will have role in some patients, and we need to have further data on that. At the moment, it still is something which remains beyond the reach of most funding authorities across the world. And ADMIRE CD2 trial, which we are recruiting to currently, will give us a little bit more information. But do I have some optimism about stem cell therapy? Is just based upon this comparative data. Now, ADMIRE trial had a week 52 follow-up, and though in those patients who did improve, they actually had sustained improvement. But if you go back and look at the original ACCENT data, you can see that by week 54, your response seems to be almost halved. So perhaps in relation to persistence, and if you take cost into consideration in relation to persistence, there may be role for MSC stem cells in fistula. What about non-anti-TNF biologics in perianal fistula? The data is somewhat limited. Most of them are post-hoc analysis of licensing trials or observational study data. There is a randomized controlled trial by David Schwartz and colleagues, the so-called Enterprise trial, which is actually the fourth on this systematic review, which looked at vedolizumab, and this trial has been criticized for a variety of reasons, but it did seem to suggest there may be some role. But I think I'm not fully convinced. That is what my experience in clinical practice. There is limited role for vedolizumab in fistula, but we await more data. Ustekinumab and the other newer agents, including the P19, I'm sure we will have more data. Certainly, guselkumab, the fusion trial, guselkumab is just about to be launched across the world, looking at specifically fistula cohort. Another experimental therapy which we have used on few occasions with, I should say, rather disappointing results in our setting was hyperbaric therapy. Although this meta-analysis seems to suggest that it may have a role in some refractory cases of fistula. So coming back to what I said earlier, the sobering fact still remains that not all patients heal and close fistula, and even in the Crohn's scenario, where our ceiling is of treatment efficacy is mostly around 50% in relation to luminal disease, in fistulizing disease remains much lower. And there can be a number of things in which we can address, and this comes back to our own data where we have addressed some of these. First thing is to understand that there are complex fistula tracts, so really evaluate these patients thoroughly, including using MRI. Understand the importance of having adequate drug levels. So inadequate PK-PD relationship may be one of the aspects, particularly if you are using anti-TNF. So that is something which we can work on. Look for the presence or persistence of abscess, and again comes back to the role of antibiotics and re-evaluation and examination under anesthesia. Always look for the high pressure zone, look for any anal stenosis, and if it is there, that will need either dilation to have a better control of your fistula tract. And I briefly touched upon the impact of epithelialization of fistula tract in relation to long-term ketone use. But in the end, perhaps the most important aspect is dysregulated inflammation, which we are still grappling with. And that's why we do have a fistula research group which was formed a few years ago, and you may recognize some of the people in the photograph, although I have since substantially aged in relation to the hair color at least. So we set up, as part of this collaborative, a large prospective study called the Gondomar, with the aim of recruiting over 6,000 patients with Crohn's disease perianal fistula across UK, but now this has been extended outside of UK too. And this is a collaborative work including not just physicians and surgeons, but also immunologists, geneticists, and radiologists. But key part of this was patients, who has now helped us to have a formal quality of life scale developed to evaluate our interventions, and these are developed in close collaborations with the patients themselves, who have experienced the traumas and the challenges of fistula. We've also developed some core outcome sets for evaluating in clinical trials. This is one of our fellows, Kapil Sahnan, who developed these core outcome sets, and these will be the basis for future randomized controlled trials when we are evaluating interventions. We also have developed a new classification for fistulizing perianal Crohn's disease, and this is more in real life practice, what is important for you and me as practicing gastroenterologists or colorectal surgeons, and most importantly, what is important for the patient. So we've divided based upon what patients' views are in relation to their goals of treatment, and also not allowing patients needing to be in a chronic state of repeated interventions and repeated trauma from constant and debilitating symptoms. So we are looking at specific targeted randomized controlled trials in various classes of this new classification. For example, class 2A patients, these are patients who had good response to anti-TNFs, but they still can't get their ketone out, they still have some leakage, their disease is well controlled. They may be eminently suitable for one of the repair procedures which I highlighted, and we are going to compare that with standard of care treatment in an upcoming trial. Similarly, at the other end of the spectrum, those who have severe symptomatic disease which is rapidly progressive, they may require a defunctioning stoma to relieve their troublesome symptoms before we introduce additional treatments. Then there is advances from our group which are looking at further detail about how we can use imaging not only for training and planning of treatment, but also personalization of treatment by demonstrating to patients and also their carers about how the fistula is. We are even able to make 3D printing of these images so that patients can understand what their choices are, whether to have a ketone in place long term or have additional interventions. Finally, our group is working on understanding the differences in relation to immune pathways in patients with Crohn's disease perianal fistula. This is one of these work which has been just published from Nick Powell's and our colleagues from Imperial, which has identified these iNKT cells which appears to be important in immunopathogenesis of fistula patients, and some of these have got therapeutic relevance because these are also mediated by these are mediated by IL-17, which opens up another therapeutic approach. So that was kind of a whistle stop tour of perianal Crohn's fistula. I hope I've shown you that it is common, but equally importantly, it can be a troublesome complications. Current treatments are only moderately effective, but there are some of the strategies I highlighted which may allow us to maximize the potential benefits of existing therapies. There are new approaches which are coming. For that, we need to have more research at not only the bench level, but also at bedside level. And some of that work is already ongoing. And I hope you can collaborate in some of those work in future. Thank you very much for listening.
Thank you very much, Professor Sebastian, for tackling such a difficult diagnosis and giving us the history, status, and future direction for research in that field. I was wondering, Dr. Sebastian, had anybody looked at the connection between mucosal healing of Crohn's disease using biological therapy and response of the fistula? Do they correlate in any way, or they're just totally unrelated?
No, I think that's a really good question. Yes, it has been indeed looked at. Patients, this is what we call as the so-called downstaging concept in relation to one of the trials which we are doing right now, is to those patients who have mucosal disease, i.e. luminal disease, including rectal disease. If we achieve healing, that means you are downstaging in the new classification from a 2B or a 2C to 2A, and then you surgically intervene to close the fistula tract. That means you have essentially completely eradicated the fistula. Is that possible in all patients? The answer is absolutely no. Is that the goal? It definitely is the goal. What patients do want is actually a closed fistula tract, as well as avoiding the need for any interventions which interfere with their continence.
Professor Sebastian, it was really a great lecture and wonderful updates. I have a question as an immunologist that we usually face in our joint management of these patients. Many of the cases having fistula, they are usually a complication of uncontrolled disease. And these patients are usually inadequate responders to treatment. This makes a great challenge in the roadblock. Some of them are highly steroid dependent. And I have seen in your presentation that using steroids might lead to worsening of the fistula. So if we discontinued the steroids in these patients, would it be safe to continue on azathioprine and anti-TNF therapy alone, even though the patient is having uncontrolled disease regarding the mucosal lesions and they are only controlled using the high dose to moderate dose of steroid? What's your kind opinion?
Yes, it's a really great question. In my opinion, steroids as long-term treatment of inflammatory bowel disease is not appropriate. Okay. Particularly now, because we do have more than one mechanism of action of treatments available in Crohn's disease. It doesn't mean that steroid use is a failure, but long-term steroid use in inflammatory bowel disease has been shown in numerous studies as probably the single most risk factor for complicated disease. That applies to both luminal disease as well as this thing. It doesn't mean you cannot use steroids at all, but long-term use definitely not something what we would advocate. Yes, you're absolutely right. There are some patients, I briefly alluded to that, only with our best treatments currently available. We have a therapeutic ceiling in most patients, somewhere around 40 to 50%. However, it's not the same group. So if we can change the mechanism of action or class of agents, you might have some additional incremental benefit. But the answer, you're absolutely right. The answer will come from clever people like yourself, probably the immunologists and the basic scientists, and I work with some really talented and incredibly clever immunology colleagues in Imperial and also in Cambridge. And we are looking at what are the drivers in those patients who have refractory disease. Are there transcriptome changes which is happening in a particular subset of patients? You may have already seen some of those data in relation to CD8 cells in the new trial which we are biomarker stratified trial called the profile trial, which we are doing, looking at people or patients who have this refractory phenotype of disease. Yes, it's an unmet need, and hence the need for more research, including at bench level. Which is the intention. So we are doing things like mapping out the whole immune phenotype, immune landscape of the entire fistula tract in proctectomy specimen using a generous funding from Hemsley Trust, and a number of other streams of work are going on. But it's a really great question. We don't have answers how we manage some of these patients, but long-term steroid is something which I would caution against.
Okay, thank you so much. Thank you.
We have one more question for Professor Sebastian.
Oh, thanks for the nice presentation and this lecture. I would like to ask about the trials comparing the infliximab with ciprofloxacin against infliximab with placebo. We noticed from the trials that the difference is big difference, although it is not statistically significant. But there is a difference reaching up to maybe 15 or 20% difference in the closure of the fistula. What do you think the cause for that?
It's a really, really great question, and it is of particular interest to us. In fact, one of my fellows is working on this. You may have, I think there are two potential explanations. One thing can be very simple as better control of the sepsis, which is, or local sepsis, if you want to call it, even after the drainage or even after examination under anesthesia and drainage and ketone. That could be simple one explanation. But I think more plausible is the impact of quinolones on the PK pharmacokinetics of infliximab. You may have seen, and I encourage you to have a look at the gut paper, which did show the relationship of quinolones, use of antibiotics, quinolones with TNF agents, which actually improves the PK/PD profile in those who are using. So it may well be purely an impact of the dosage. The two trials which I showed you, they used standard dose of infliximab. At least in our center for perianal fistula, we right up front, we use higher dose of anti-TNF. And even then, we are still using ciprofloxacin based upon the data. So it's a really great question. The reason is one of the two possibly, or there may be something which we don't fully understand, but we are looking at this locally.
Thank you very much, Professor Sebastian. We're now going to move to our next speaker, Professor Maha Saballah. Professor Maha Saballah is a professor of endemic hepatology, gastroenterology, and infectious disease in the Faculty of Medicine, Cairo University. Professor Maha is an expert in both diagnostic and interventional ultrasonography, and she is definitely the pioneer of bowel ultrasound in Egypt. Prior to her work, it was just fiction. Talking about bowel ultrasound was fiction in this country. For the past 20 years, she's been making huge strides in that field, and she's training generation after generation of fellows and specialists in the field. She is the former director of the Focus Ultrasound Unit and the current head of the Endemic Medicine Diagnostic and Interventional Ultrasound Unit. And I'm proud to call her my dear friend, Professor Ma.
Thank you very much, Professor Hisham. This is much more than I deserve, and I'm honored to be with you here today. And I'm very happy that most of the attendants are of our young generation who will carry the responsibility of medical practice and education in the coming years, inshallah. I'm here to send you a message of the value of gastrointestinal ultrasound in inflammatory bowel diseases. In fact, it's the value of ultrasonography for us as clinicians and gastroenterologists in each topic, not only in the IBD. So, why do we need ultrasound in bowel examination? Ultrasound is peculiar and it has superiority over the other cross-sectional imaging in being real-time imaging, because CT and MRI are not real-time. By ultrasound, we can see peristalsis of the bowel loops, compressibility, and much more ongoing things in the body. And again, ultrasonography has a panoramic view, so we can see the bowel wall, its layering pattern, and the peri-intestinal structures, not only the mucosa. And we all know that ultrasound is a safe procedure. It's free of radiation and free of dyes and gadolinium like MRI. And we can use other procedures or options that can help us while doing the plain ultrasound by giving oral contrast ultrasound using polyethylene glycol that might increase the sensitivity for small bowel examination. Gastrointestinal ultrasound is now recommended to be used to detect the IBD at its first presentation, to assess its disease the disease activity, and to detect the complications. And this is recommended by the ECHO, the ISCR, and the European Federation of Studying Ultrasound in Medicine and Biology. And what are we going to do when are we facing a case of IBD? First, by ultrasound, we are first going to have a very clear clinical scenario about the patient. Having history, this is very important. Doing a perfect clinical examination, this is complementary to getting the best yield of ultrasound examination. Ultrasound is used to detect the pathological bowel segment at the time of presentation, and we all know that Crohn's disease affects the small bowel loops, and that the small bowel loops is a hidden area that couldn't be examined clearly by endoscopy. It also differentiates Crohn's disease from ulcerative colitis, and we will see together. And it can determine disease activity and predict the need for surgery. And we can follow up patients of IBD using ultrasound, not by endoscopy each time. And I will show you one by one. First, we have to know that the most important significant sign of bowel disease is bowel wall thickening. And the normal bowel wall shouldn't exceed 3 millimeters in thickness. So whenever the bowel wall is pathological, it becomes thickened more than 3 millimeters. And we can even assess the bowel wall stratification, not only the thickness, and we can assess the submucosa, because the submucosa, I will show you now, is considered a very important layer. Whenever it is thickened, this means an indication of activity. And if there is loss of bowel stratification, this also means that we have severe disease or tendency for ulcerations. So as we see here, we all know the differences between Crohn's and ulcerative colitis. We all know that Crohn's disease is affecting multiple short bowel segments, and it is mainly affecting the ileocecal region, and it's famous of skip lesions, and it causes more pronounced bowel wall thickening, more than 1 centimeter width than ulcerative colitis, and it has a tendency to do asymmetrical bowel involvement and disruption of the wall layering pattern. To the contrary, ulcerative colitis affects long bowel segment. It starts from the rectum upwards continuously with no skip lesions, and it causes much less pronounced bowel wall thickening than Crohn's disease, and it has a tendency to cause a uniform bowel thickening with preservation of bowel wall layering pattern. I'll show you here. Here we have a segment of the sigmoid colon. This is the left iliac vessels, and we refer always to the landmarks. Here we have the left iliac vessels, and this is the sigmoid colon showing diffuse wall thickening with preservation of the layering pattern. As you see here, we can see the echogenic mucosa in the lumen, and then the hypoechoic muscularis mucosa, the echogenic submucosa, the hypoechoic muscle layer, and the echogenic serosa. And this means that the disease preserved the wall layering pattern, and this is what ulcerative colitis does. It causes uniform thickening with preservation of wall layering, and it usually causes wall thickening less than 1 centimeter. And then in the same patient, here we can see the right iliac vessels down here here. This is the right iliac vessels, and then we have the terminal ileum diffusely thickened with preservation of wall layering pattern, and this is what we call backwash ileitis in ulcerative colitis. And you can notice the uniform wall thickening and the preserved wall layering pattern. In contrast to Crohn's disease, which usually causes short segment of diffuse bowel wall thickening, here we can see the terminal ileum, the mucosa or the air mucosal interface, which is the echogenic inside, and the wall that is thickened with no clear layering stratification, because this is a terminal ileum affected with Crohn's disease with tendency of asymmetrical thickening and loss of wall layering. And then the rest of the differences between Crohn's and ulcerative colitis, that ulcerative colitis doesn't cause any periintestinal pathology, because we all know that it's a mucosal disease, while Crohn's disease is a transmural disease. So it causes periintestinal lesions like abscesses, fistulae, and sinuses. It also causes some mesenteric fat creeping, I will show you, and lymphadenopathy is not a feature of Crohn's disease. The lymph nodes in Crohn's disease are very non-specific, and it might involve the appendix, causing appendiceal thickening, and there is no ascites with Crohn's disease. To the contrary, in ulcerative colitis, we have no periintestinal lesions, no sinuses, abscesses, or fistulae, and we have no mesenteric thickening, no lymphadenopathy, and no involvement of the appendix, and we might have minimal ascites in patients with severe colitis. And then I will show you here. Here we can see a terminal ileum with diffuse wall thickening in a patient with Crohn's disease, and we can notice the loss of wall layering pattern and the asymmetrical involvement. And then this same patient with terminal ileal thickening, as we can see here, has a fistulous tract with air inside. The fistulous tract is arising from the mesenteric border of the thickened small bowel loop here, with air, this echogenic foci within, going down to reach into a fluid collection posteriorly, as we can see here. Here we can see the fistulous tract and the fluid collection posteriorly. So we have a complicated Crohn's disease with periintestinal fistulous tract and periintestinal fluid collection. And then again, we have here multiple loops of diffuse small bowel thickening seen in cross sections, with one of them showing again a fistulous tract that is hypoechoic with air inside reaching into a periintestinal fluid collection. All these are features of Crohn's disease. Ulcerative colitis, as we see here, we have a segment of the bowel with diffuse wall thickening, rather uniform with preserved wall layering, and with no periintestinal lesions, no fistulous tracts, no abscesses, no lymphadenopathy. This is how ulcerative colitis behave. And then for the other uses of ultrasound in inflammatory bowel disease, we can assess the disease activity using ultrasound, and an active disease should have bowel wall thickening, and we should see increased intramural vessels on color Doppler examination. So I will show you now, and if we have persistence of bowel wall thickening despite treatment, this predicts the need for surgery. And if we have persistence of increased intramural vascularity after remission, this suggests the risk for relapse. And let's see together. This is a segment of the colon, the left colon, showing wall thickening that shows uniform thickening and preserved layering pattern. And we can see here increased intramural vessels on color Doppler examination denoting activity. And again, this is the terminal ileum of the same patient with much increased intramural vascularity within the wall, as you see, denoting activity. The wall thickening and the intramural vascularity both indicate that this patient is in active disease. And here we have a segment of the terminal ileum with diffuse wall thickening and also increased intramural activity, vascularity in a patient with Crohn's disease. And as we see here, this is duplex Doppler examination with arterial signals seen within the wall, denoting inflammation and increased vascularity because of the active inflammation. Ultrasonography could be used to follow up the patients on treatment and after surgery, and we can judge the patients with reduction of the bowel wall thickening. Reduction of the thickening indicates good response, while recurrence of bowel wall thickening more than 3 millimeters after normalization, or increased intramural vascularity, or the appearance of complications all indicate poor response. And we can also detect complications using gastrointestinal ultrasound. And we all know that the complications of Crohn's disease are much, and that we cannot detect these complications only by endoscopy. We need cross-sectional imaging. And then we will see here that Crohn's disease might cause stenosis, sinus formation, periintestinal abscesses, and fistulization. So let's see here. We can see the same patient with diffuse terminal ileal thickening, a hypoechoic sinus tract with air inside arising from the mesenteric border of the second segment and reaching down to the right psoas muscle, causing a right psoas abscess. And we can see here, this is how extensive was the abscess. This was a very miserable patient with a huge right loin swelling because of abscess formation. And unfortunately, surgeons at this point refused to intervene, and they asked us for a minimally invasive procedure, and we were obliged to put a pigtail catheter, as you see here. This is the tip of the pigtail within the fluid collection to drain the abscess cavity. And then the patient received antibiotics, and after which he started biological therapy for a trial of healing, or to trying to heal the fistula before surgical intervention. And I'm not sure if he had done the surgery by now or not yet. And then here we can see a terminal ileal wall thickening in a patient with Crohn's disease with partial loss of wall layering pattern. And we can see by Doppler examination that it has too many vessels within the wall, indicating activity. And we can see by duplex examination that these vessels are of arterial signals. And I'll show you here that this second segment had a peri-intestinal fluid collection having a wall, thickened wall, echogenic fluid, and air inside, denoting that is related to the affected segment. So this patient had a peri-intestinal abscess that we have aspirated for relief, and after aspiration it gets collapsed, and this collection was very much related to the urinary bladder, as you see. Another patient, all of these are our patients in the endemic medicine department, Qasr Al Aini hospital, and here we can see the urinary bladder, and this is a second bowel segment posterior to it, with air seen tracking through a sinus tract to the urinary bladder from the lumen of the thickened intestine. So this was a patient with Crohn's disease and enterovesical fistulization, and we can see here that the urinary bladder contains echogenic urine and air inside, as you see. And the patient was complaining of fever, abdominal pain, diarrhea, and pneumaturia. Maybe our colleagues and our residents and all of our staff members in the department know much about these patients than me. They can continue the story if I will ask them now. And then this same patient having rectal thickening and retrorectal fluid collection that is measured posteriorly. So we can even sometimes in thin patients examine the rectum by ultrasound, by transabdominal ultrasound, and judge it. But the best for rectal examination by ultrasonography is to do an EUS or transrectal ultrasound. And then here, a diffuse wall thickening of the sigmoid colon with preserved wall layering pattern in a patient with, as we see, multiple segments of bowel thickening. And we can see here the lumen with air of one loop and the other loop and the third loop. And we can see together that the air in the three loops met together in a point, and this means that the three loops communicated together. This is enteroenteric fistulization, and this was a patient with active Crohn's disease with enteroenteric fistulization, and we call this the star sign. And then we can find out the stenotic segments, and finding a stenotic segment is easy because usually proximal to the stenotic segment we have dilated bowel loops, and the dilated bowel loops are hyperperistaltic, and we can see this in a real-time pattern on ultrasound. So we can see a dilated loop with hyperperistalsis, and when we trace it down, we can see a thickened segment. This thickened segment is the site of stenosis, beyond which there is no more dilatation, beyond which there is collapse of the bowel loops. The stenotic segment might be either inflammatory or fibrotic, and we can differentiate both by using contrast-enhanced ultrasound that we don't have in Egypt, but we can substitute it by using color Doppler examination. So here we can see a dilated bowel segment with a diffusely thickened segment here. This is the terminal ileum. The wall is thickened concentrically with an eccentric lumen, a narrow eccentric lumen with proximal bowel dilatation in a patient with Crohn's disease. This patient was operated upon surgically, and this is another picture of a diffusely thickened terminal ileum with preserved layering pattern and a proximally dilated segment. And I'm sorry because I don't have a video now to show you, but those patients usually respond well to surgical resection of the thickened stenotic segment. For ulcerative colitis, we don't have much complications, either massive pseudopolyposis and malignant change or toxic megacolon. And I will show you now. Here we have a thickened segment of the bowel with diffuse wall thickening, and we can see here that the mucosa is like irregular in shape with air seen in between the irregular echogenic mucosa. This looks like pseudopolyposis formation in a patient whose colonoscopy showed pseudopolyps. So this might be the picture of pseudopolyps on ultrasound. And here there was a patient with severe ulcerative colitis having diffuse, you see here, this is the sigmoid colon with concentric diffuse wall thickening and layering pattern that was preserved. And this patient has an acute abdominal pain with vomiting, abdominal distension, and what looks like intestinal obstruction, constipation, and absolute constipation. This was a dilated transverse colon. As we can see here the anterior wall that is thinned out, the lumen that is full of air and luminal contents air and fluid. And then we can see also here a dilated right colon. This is the anterior wall and a posterior wall with much increased diameter and increased intraluminal fluid contents. And this patient, these features look like the toxic megacolon. So we suspected toxic megacolon on ultrasound, and the plain X-ray showed a hugely distended transverse colon that confirmed the picture. This patient was conserved upon medically with antibiotics, IV fluids, and bowel rest, and he passed this surgical emergency. He wasn't operated upon. Sonographic quantitative scores in Crohn's and ulcerative colitis are ongoing now. We are trying, and everybody is trying to find out an accurate quantitative sonographic score that usually depends on some parameters like the bowel wall thickening, the stratification, the vascularity of the intramural vascularity, and the aim is to be able to assess the severity of the bowel damage and to assess the risk of surgery, reducing the need for endoscopy each time so as to follow up the patient in a non-invasive way. And all the scores are in the stage of construction and validation. Let's step further now from the very classic thinking and the very classic teaching of ultrasound in IBD, and I want you share with me this next coming few minutes, and I will show you here how a clinician with the ultrasound in hand can get the best benefit of the ultrasound if he's trained and if he knows what to search for, and if he has a very good clinical scenario in mind. Not every bowel wall thickening is Crohn's disease or ulcerative colitis. Sometimes we have too many things other than this. And when you are faced with a patient with abdominal pain, diarrhea, or bloody diarrhea, you don't know what about this patient, if he's going to be an IBD or something else. So I want to show you, we will share together this. How can a clinician use things that are very teachable? We can all learn this, and we can all use this to benefit the patients, and I'm inviting you all. I'm inviting all of the attendants to learn ultrasound well and to learn bowel ultrasound so as to be able to help the patients and help themselves and not to do too much investigations unneeded. So how could we use ultrasonography, or what's the value? The value of ultrasound in bowel examination is to do a panoramic bowel examination. We can see the bowel wall thickening as we saw together just now, the bowel wall layering and the peri-wall structures, and the peri-intestinal lesions, the mesenteric thickening and mesenteric adenopathy, the omentum and the peritoneal structures, and the rest of the intra-abdominal organs like the liver, the spleen, the lymph nodes. This is with the clinical scenario in mind. This is the first to start with. We can reach a definitive diagnosis, or we at least can minimize the list of differential diagnosis. So let's see together. I want you to share with me. I will tell the scenario, show you the pictures, and let's think together, please. This is a 25 years female patient presented with colicky abdominal pain, chronic diarrhea, sometimes bloody for the last 5 years. She had undergone colonoscopy several times, enterography with ileocecal and sigmoid ulcerations detected. Histopathological examination revealed chronic non-specific inflammatory cells. And the patient was treated as a case of ulcerative colitis with worsening of her abdominal pain and diarrhea. She was sent to the endemic medicine department, our department in Qasr Al Aini, for reassessment. On examination, she was pale, cachectic, with a body weight of 35 kilograms on presentation. She had a scaphoid abdomen. There was no organomegaly or palpable masses, and her intestinal sounds were hyperaudible. And I'll show you now, this was the terminal ileum that was seen diffusely thickened with loss of wall layering and increased intramural vascularity denoting activity. And there was also some thickening of the sigmoid colon in such a patient. And then while we are screening her abdomen, this is the terminal ileum, this is the cecum, and there was also diffuse terminal ileal and cecal thickening. So this patient had more right-sided affection. And then while screening the abdomen by the conventional frequency transducer, we started to notice some mesenteric lymph nodes. We used the high frequency transducer to verify it more, and we started to see these large, rounded, hypoechoic mesenteric lymph nodes with calcifications within. As we can see here, these are multiple confluent hypoechoic lymph nodes with calcifications. And I want to ask you now, if this patient could be Crohn's disease, ulcerative colitis, or there might be another diagnosis. What do you think? By now, at the level of the ultrasound, while seeing bowel wall thickening, terminal ileum and cecal, and very large, rounded, hypoechoic mesenteric lymph nodes with calcifications. What do you think? Yes, you are right. Whenever we see enlarged lymph nodes with calcifications, it can never be Crohn's disease. This can never be Crohn's. So we decided to take a biopsy from one of these large lymph nodes. At the same day, her gene expert for TB was positive, and this patient proved to be a tuberculous ileocecal and sigmoid affection that she was treated as a patient with ulcerative colitis for 5 years. And I think that all of our staff members know this patient, and she's now very good. She finished her anti-tuberculous treatment, and she gained weight, and she got pregnant, and she had another baby after being a healthy person. So I can show you here how could ultrasound turn the diagnosis and target the patient in a right way. And then the second case is a 20 years male patient that presented with right lower abdominal colicky pain, diarrhea, and fever of 38.5 degrees for the last 3 months. He had 10 kilograms of weight loss. He had colonoscopy done, showed ileal ulcers, and he started steroid therapy, also with worsening of his condition and accentuation of diarrhea. He was referred to us with, on examination, there was right iliac fossa fullness and tenderness elicited on examination. So he's also a young patient with diarrhea, loss of weight, fever that didn't improve on steroid therapy. And as we see here, we have a diffuse terminal ileal thickening with some visceral peritoneal thickening and reaction. And we can see here an echogenic band anterior to the thickened bowel segment that is not a bowel loop. It's a solid band with no air and no lumen. So this is an omental band of thickening. And we can see again a hypoechoic solid lesion indenting this thickened terminal ileum. This is with a conventional frequency transducer. And when we used the linear transducer, we can see the second omental band clearly with a solid hypoechoic lesion within. And I will ask you again now, could this patient be Crohn's disease, or he might have another diagnosis based on the clinical history we have seen and this ultrasonographic picture? What do you think? You know, Crohn's disease doesn't cause any peritoneal affection. It doesn't cause omental thickening, neither omental nodules, doesn't cause peritoneal thickening. So whenever we have omental lesions and peritoneal lesions, we should think about TB. And we all know that Crohn's disease and TB are very similar, and they are very challenging. Sometimes we cannot diagnose the patient. So it was very accessible and superficial, and we did again an ultrasound-guided biopsy of this omental nodule, if we can name it like this, and this patient was proved to have tuberculous enteritis with tuberculous peritonitis, and also he improved a lot on anti-tuberculous treatment. Are you ready for the coming case? A 30-year male who was known to have familial neutropenia. He presented with recurrent colicky abdominal pain and diarrhea for the last 5 years. The attacks were usually accompanied by fever, sometimes necessitating hospital admission. So this patient here was a young patient with neutropenia and abdominal pain and recurrent diarrhea. He was complaining of low back pain also, colonoscopic examination done twice, and he was diagnosed as Crohn's disease according to the presence of terminal ileal ulcers. The patient was on 5-AZA and intermittent steroid therapy with frequent exacerbations. 10 days before his presentation, he experienced fever reaching up to 39.5, increased frequency of watery diarrhea, dysuria, and severe right lower abdominal pain. On examination, the patient was toxic, cachectic, tachycardic with a low blood pressure. He had right iliac fossa tenderness and fullness, but there was no masses detected. And we can see here again a terminal ileal thickening with preserved wall layering pattern. This patient was diagnosed as fistulizing or sinusizing Crohn's, so we can see here the cecum with diffuse wall thickening and preservation of the wall layering. And on color Doppler, there is increased intramural vascularity, so he has ileocecal thickening. And we can notice a periintestinal fluid collection or a pericecal with a thickened wall and echogenic fluid. And we have done ultrasound-guided aspiration of this fluid collection to relieve the fever and the pain, because this patient, this time he had fever, high fever. Here again we can see the ileocecal thickening, the preserved wall layering, and periintestinal fluid collection, and all of these can match with a patient with Crohn's disease. And then this is the right kidney, and we can see here hydronephrosis. The pelvis is dilated. This is the calyceal dilatation and a pelvic dilatation and an echogenic ball or a structure inside a dilated calyx, and based on which this patient was suspected to have a fungal infection because he was neutropenic and he had what looks like an echogenic structure like a fungal ball or whatever in the pelvis of the kidney with no posterior shadow. It doesn't look like a stone, and I'm not sure if the histoplasma antigen in this patient was a positive in urine. I think he was diagnosed as a case of histoplasmosis, and what I want to show you is that ileocecal thickening with preserved wall layering pattern in such a way could be another infection. And in a patient with neutropenia, he could have a fungal infection with fungal infection of the kidney. And this patient was in a very poor general condition. And he didn't stand the infection. He didn't withstand the infection because it was repeated several times in a short time.
Dr. Maha, if you excuse us, we have 2 minutes left.
2 minutes?
Yes.
So I'll tell the last case. I have too many cases. I'll talk to the attendants outside, Yarim.
It's really very interesting, and I'm considering to make a workshop on these cases to be led by your side, طبعا, as an expert in ultrasound. This would be great. But we have another 2 lectures, so if you excuse us, we have 2 minutes left.
I'll show you this last case, a 48 years male patient, had sigmoid resection done for perforation 2 years ago. He was diagnosed as a case of Crohn's disease. He was non-compliant on treatment. He presented with fever of 38.5 and multiple sinuses in the left line that were discharging pus, and this started 2 months before his presentation. There was left lumbar and left iliac fossa tenderness with 3 sinuses seen discharging pus in the left lumbar region. So this patient had sigmoid resection and diagnosed as Crohn's disease and developed sinuses with pus discharge, and we can see here the diffusely thickened part of the small intestine with preserved wall layering pattern, and then by the conventional frequency transducer, as we see here, this is a diffusely thickened small bowel loop, and this is the mesentery of the small bowel, and this is mesenteric vessels, and we can see an expanded mesentery with hypoechoic structures infiltrating the mesentery. Again, this is the same picture with thickening of the bowel loops, expansion of the mesentery with hypoechoic masses infiltrating. And then this was the perianal or the sinus tract in the abdominal wall by high frequency transducer. And this patient had also ascites at the time of presentation. And this is again not a feature of Crohn's disease. Crohn's disease doesn't cause ascites. So after too many consultations, we did an ultrasound guided biopsy of the hypoechoic tissue within the mesentery. It wasn't lymph nodes. It wasn't actually lymph nodes, but infiltrating tissue that doesn't match also with Crohn's disease. And the biopsy revealed an actinomycosis. This patient was proved to have actinomycosis of the mesentery and maybe secondary infection to the, when he was a Crohn's disease patient, this might be a secondary infection with actinomycosis, discharging pus into the outside, and he started treatment for the actinomycosis. He started antibiotic treatment. So I should stop now, but what I want to send you is try to get benefit of the ultrasound as much as you can, because by ultrasound we can very much minimize the differential diagnosis, and we can help the patients either by diagnostic or by diagnostic and therapeutic procedures. So thank you very much. We have everyday cases like this. You are all invited to come to our department, and you are all invited to learn this and to be able to manage the patients in a better way. And thank you all, and I'm sorry.
Thank you so much, Professor Dr. Maha. It was really a very spectacular presentation, and it was really special to all of us. الحقيقة يعني ده خلاني أقول حاجة إنه إحنا بنفكر إن إحنا من ضمن السكيل building plans بتاعتنا in Egypt. I think an expert زي حضرتك ممكن to lead a workshop in diagnostic ultrasound in the field of inflammatory bowel disease, and this will be our next plan if you allow us to. You are a great expert. It's our pleasure to host you with us. Thank you. And let me introduce to you the next speaker, Professor Dr. Hisham Marzangi. Dr. Hisham is going to give us a talk on the updates in the management of inflammatory bowel disease.
اوكي مساء الخير جميعا. انا عارف ان انا الحاجه الوحيده اللي منعكم من العشاء دلوقتي، وانا بقيت بني ادم مكروه جدا قبل ما ابتدي والله. معلش سامحوني. Okay, I'll try to be quick. I was giving instructions by the chairman to finish quickly, so I'll do my best. This title, IPD Management Update, or I'd rather call it Updates in the Management of IPD, is two parts. Part for the juniors, the fellows, practical, and part for the older people, the experts. So let's start by the older people first. Okay. Updates in the field of IPD are predominantly related to developments in the field of biologic. There isn't a conventional treatment that has appeared in the past maybe 30 years. All the new innovations are in the field of biologics. So these are the biologics that are approved currently for use in both Crohn's disease and ulcerative colitis. If we take Crohn's disease, the story started in '98 with Remicade, followed by adalimumab in 2007. A year later, citralizumab, and 2014, vidulizumab, and then finally 2016, ustekinumab, and then there is nothing else. For ulcerative colitis, it's been wildly more active. In the past 3 years, we had 3 or 4 new biologics appearing. In 2018, it was tofacitinib. In 2019, it was the ustekinumab. In 21, there was the Zeposia. Some of you may know it from neurology, as it is a treatment for multiple sclerosis initially. But it gained FDA approval for treatment of ulcerative colitis in 2021. And only this year, 2 months ago, the obadasitinib, or the Rinvoq, has gained FDA approval and EMA approval only 2 weeks ago. So this is the brand new drug. Now, we'll talk about the 2 new drugs that most of us haven't heard of lately. Let's start with the obadasitinib. It's FDA approved for the treatment of adult patients with moderately to severely active ulcerative colitis who have had an inadequate response or intolerance to one or more of TNF blockers. So it's a very specific indication. You need somebody who's been treated with a biologic and failed treatment with a biologic from the anti-TNF class to qualify to take the obadasitinib. Okay? What is it? It's a JAK inhibitor. Do we know another JAK inhibitor in the market? Yes, we do.
Excuse me, can I kindly, just a second, can I kindly request silence to be able to listen to the lecture? Thank you so much.
Okay. Right. There's the tofacitinib, which is the Xeljanz, which you all have heard about. So this is another JAK inhibitor. It's given in 2 phases, induction phase and maintenance phase. The induction phase is giving 45 milligram once daily for 8 weeks, and that is the upside. It's given only once daily. And the maintenance dose is 50 milligrams once daily, and we can escalate to 30 milligrams in people who are not responding or people starting with a very severe disease. Now, this drug is again another biologic agent that we borrowed, or dare I say stole from rheumatology, because it's initially developed for rheumatoid arthritis, psoriatic arthritis, and atopic dermatitis. We are the 4th indication. We used their basic research. Now, what is the data that we have? These are the pivotal trials. We've done induction trials and maintenance trial. The 2 trials on your left-hand side are the induction trials that lasted for 8 weeks and extended later on to 16 weeks. Then there is the maintenance trial, which lasted for a whole year, 52 weeks. Right. Thank you very much. Okay. Now, what is the data that we have? The data that we have is about efficacy and about complications or side effects. Now, these are the efficacy data. This is the clinical remission rate. These are the induction trials. Placebo, 5%. In the treatment group, it's 26%. What about endoscopic remission? In the placebo group, it's only 1%, while in the treatment group, it's 14%. What about clinical response? In the placebo, it's 27%. In the treatment group, it's 73%. And the ultimate aim or the ultimate assessment of efficacy of any drug is mucosal healing. The mucosa would heal or not. Mucosal healing in the placebo group was only 1%, while mucosal healing in the treatment group was 11%. So that prompted the FDA to judge that this treatment is effective. Now, this is the maintenance data, the 1-year data. This is the rate of the clinical remission. On placebo, it was 12% only. On the lower dose of the obadacitinib, it was 42%. On the higher dose, it was 52%. So if you look at this, you'll say, let's give everybody the higher dose, right? Unfortunately, the higher dose, as you're going to see in the next slide, is associated with more complications. So we still want you to give the lower dose, but only give the higher dose if the patient is not responding or having a very severe disease. What about steroid-free remission? This is remission, patient in remission without needing any steroids. Placebo, it was 22%. In the low dose, it was 57%. In the high dose, it's 68%. Endoscopic remission, 6% in placebo, 24% in the lower dose, and 26% in the higher dose. The final aim is mucosal healing, only 5% placebo, 18% in the lower dose, and 19% on the higher dose. Okay, these are the adverse events. Unfortunately, the serious adverse events in this registration trial was not vastly different from placebo, but mind you, we're not, in the real world, we're not in a clinical trial. Clinical trial patients are selected patients. There are so many exclusion criteria to make the patient unfit to be registered in that trial. What's more important, what I advise everybody here to read, is the real-life data, which usually appears 3 to 4 years after the drug is already in the market. And the actual clinicians start reporting the real side effects that they see. Registration data or clinical trials or randomized controlled clinical trials for registration of a drug are actually sometimes too good to be true. So a word of caution. Okay. The main side effects are sometimes worsening of ulcerative colitis. We're giving that treatment to treat ulcerative colitis, and sometimes ulcerative colitis becomes worse. This happens mainly with the low dose. Herpes zoster, again, like the Xeljanz, the same problem with herpes zoster, VZV reactivation, and again, elevations of creatinine phosphokinase, CPK elevation, the muscle enzyme elevation. Okay, this is a copy from the FDA package insert. This is a black box warning that comes to attract the attention of any patient. It alerts the patients to the risk of reactivation of tuberculosis, the risk of occurrence of malignancy, the risk of thrombosis and thromboembolism, and finally, a slight risk of increased mortality. Now, this is the second drug, the ozanimod or the Zeposia. It's a new category of drug. It's not anti-TNF, it's not anti-interleukin, and it's not a JAK inhibitor. It's a sphingosine 1-phosphate receptor modulator or blocker that binds to that specific receptor and lead to prevention of lymphocyte mobilization into inflammatory sites. So it prevents lymphocytes from leaving blood vessels and going into the tissue to cause inflammation. Again, it was approved initially for multiple sclerosis. The dose is 1 milligram once daily, taking orally. So it's an oral medication, which is a huge advantage for anybody with a chronic illness. Unfortunately, we cannot give the dose from the start. We have to do titration or building up of the dose. We start the first 4 days with ربع milligram, 0.5 milligram, then another 3 days with half a milligram, and then from the 3rd day we can take the full 1 milligram. Why? Because it produces bradycardia. If you introduce the full dose from the get-go, the patients sometimes develop serious bradycardias. If you titrate up, there is no problem. Okay, this is the paper from the New England Journal of Medicine that led to the FDA accepting the registration of that drug. This is the efficacy parameter. If you can see here, this is the response on induction period. Induction period in this drug is 10 weeks, not 8 weeks like every other biologic. It's 10 weeks induction. The placebo is only 6% compared to 18% in the active treatment group, so it's 3-fold increase. And again, this is the efficacy on the maintenance period. Maintenance is 1 year. Clinical remission rate superior to placebo, 18 versus 37. Steroid-free remission, 16 versus 31. And finally, mucosal healing, 14 versus almost 30%. So this is to show you that there is, again, a big difference when you give the Zeposia to somebody who's taking anti-TNF blockers previously versus naive patients. So in people who took no TNF blockers, response rates are much better than people who took TNF blockers, 10% versus 22%. And it goes for all the parameters here. Okay, again, the complications, we talked about bradycardia, again, infections like any biologic, liver dysfunction, elevation of ALT, and lowering of lymphocytic count. This is rather specific for this drug. It causes lymphopenia. Okay, now this is the more practical part for our juniors. These are the ECHO guidelines for Crohn's and ulcerative colitis. For Crohn's disease, we have induction and maintenance. How to do induction of response of Crohn's disease. If the disease is mild to moderate, you can use the budesonide. Again, there is no data to support use of 5-aminosalicylates or antibiotics. So the message is they're in red, not because they're important and I want you to know them. They're in red, don't touch them. Stop, okay? So what's in red is not effective. So no role for 5-ASA or antibiotics for induction of a remission in Crohn's disease. A lot of the audience I know are using it. No, it doesn't work. Okay, if the disease is moderate to severe, what can we use for induction? Systemic corticosteroids, this is great. TNF inhibitors, combinations of thiopurines with infliximab. We can use ustekinumab or vedolizumab. All of these are now acceptable first-line therapies for moderate to severe Crohn's disease. What is not acceptable as a first-line therapy is using drugs like thiopurines, azathioprine, yani, as a monotherapy. So azathioprine alone cannot be used to induce remission in Crohn's disease. For maintenance of this remission in Crohn's disease, again, no role for 5-aminosalicylates in the maintenance of remission at all. We can use thiopurines. They are the recommended drug for the maintenance of remission in patients with steroid-dependent Crohn's disease. We can use methotrexate for maintenance of remission in patients who are steroid-dependent. This is a great problem that we have. We never, as gastroenterologists, use methotrexate. Nobody knows why. We only use azathioprine. Although the scientific data points to equal efficacy of methotrexate and azathioprine as treatments for inflammatory bowel disease, but nobody seems to be prescribing them. On the other hand, rheumatologists are using them much more liberally, and the response rates in diseases like RA, which is our cousin on the rheumatology side, are excellent. Okay. Then, if I used a biological agent to induce a remission, then I must maintain the same biological agent to maintain the remission. There is no data to support اللعب والتغيير اللي بنعمله ساعات كتير. If I responded, let's say, on adalimumab, I shouldn't change it to another drug unless I lose efficacy or develop a serious complication. If this doesn't happen, I stay on the same drug. Okay, these are points of debate that we're not going to go through because of the time. Now, what about ulcerative colitis? Ulcerative colitis is a whole different disease, okay? The guidelines for ulcerative colitis are related to the location. Which part of the bowel is affected? Is it only the rectum? Is it the left colon? Or is it the entire colon? Okay, let's start by proctitis. If I have only proctitis, the drug of choice is mesalamine, 1 gram suppository once daily. This is the preferred treatment. Other forms of mesalamine, like foams or enemas, can be used, but suppository is superior to them. Topical mesalamine is more effective than topical steroids, and this is a paradox. I know everybody here has tried the topical mesalamine, and when it doesn't work, they shift to topical steroid. No, the topical mesalamine is more effective than the topical steroid. Okay? Now, combining, on the other hand, the topical mesalamine with an oral mesalamine or a topical steroid is more effective. So if the patient is not responding on topical mesalamine, add a steroid. Do not replace. Okay.
Can you start with both together? You can start with both together.
It's not in the guidelines. It's not in the guidelines, but yes, you can. Sure. Refractory proctitis may require treatment with systemic steroids. Now, what about if the disease is a bit more extensive? If it's left-sided ulcerative colitis? Now, if it's left-sided ulcerative colitis, it's mild to moderately active. We should initially start treatment with aminosalicylate, enema, 1 gram per day, combined with oral mesalamine. You can notice here that we shifted to enema because this is left-sided colitis, not only proctitis. For proctitis, you can put a suppository. For left-sided colitis, you have to go for an enema. Now, the dose of oral mesalamine is at least 2.4 grams per day. Once daily dosing with mesalamine is effective, then you don't have to give mesalamine in divided doses. You don't have to give it صبح وظهر وبالليل or صبح وبالليل. It's just as effective if you give it all in one go. You can give the patient the entire amount of mesalamine that he needs per day, and he would have it in one go. This is better for compliance. If you ask the patient to swallow 2 pills 3 times a day, you can be sure that he will not do it strictly. He will miss doses. Okay. Systemic corticosteroids for patients with moderate to severe activity and in those not responding to mesalamine. So the first line for left-sided ulcerative colitis is mesalamine. Then, if that doesn't work, you go for systemic corticosteroids. There is a role for budesonide, yes, 9 milligrams per day, in patients with mild to moderate disease activity who are not tolerant to aminosalicylates. If there is severe left-sided colitis, then this patient should be hospitalized. You shouldn't manage him or her as an outpatient. The third and final scenario is extensive ulcerative colitis. If there is extensive disease affecting the whole colon, if it's mild to moderate disease, we should start with aminosalicylates enema, 1 gram per day, combined with oral mesalamine, at least 2.4 milligrams per day, at least. There is data to support that giving 4.8 grams per day is much more effective, and the remission comes much earlier than when you give the lower dose, the 2.4. But we occasionally see doses like 500 milligram thrice daily, which doesn't do anything. It's a waste of time. Okay? Now, systemic corticosteroids for patients with moderate to severe activity and those not responding to mesalamine. So we started first line, this is the second line, systemic corticosteroids. And if it is, again, a severe infection, we have to take the patient, a severe activity, we have to take the patient to hospital. what to do. What is the definition of severe activity? Diarrhea more than 6 motions per day, pulse more than 90, temperature more than 37.8, hemoglobin less than 10.5 grams, ESR more than 30, C-reactive protein more than 30. This patient should be admitted in hospital. Initial treatment is always with intravenous steroids, not oral steroids, IV steroids, okay? Or alternatively, monotherapy with intravenous cyclosporin. It's by the way, the two spellings are correct. This is the British spelling, this is the American spelling. So don't be bothered, okay? All patients should receive, in addition to this, whether you give intravenous steroids or intravenous cyclosporin, you have to give anticoagulation with low molecular weight heparin, plenty of IV fluids, correct the anemia, correct electrolyte imbalance, and rule out CMV and C. diff. Sometimes the patient have CMV colitis. This is specifically in chronic patients taking steroids. They get secondary infection with CMV colitis. You see the patient, you think it's an exacerbation, so what do? You increase the dose of steroid. Increasing the dose of steroid increases the activity of CMV, and the patient ends up in toxic megacolon. So you shouldn't do that. You should rule out the presence of CMV colitis, very importantly, and Clostridium difficile causing the pseudomembranous colitis. It's very simple. This is done by a stool test, and this is done by an unprepared short proctosigmoidoscopy. Never order a full colonoscopy in somebody with severe ulcerative colitis. It's a risk of perforation and toxic megacolon. And please, preparation by itself, giving the patient the usual movie prep or whatever, increases the risk of toxic megacolon. So never give a preparation and never attempt to do a full colonoscopy. Okay, this is what to do with these patients. We give intravenous steroids. If the patient is not refractory, not responding to IV steroids, what do? We wait only for 3 days. We give that patient chance for only 3 days, not a week, not 15 days, only 3 days. And if the patient is not responding, we shift immediately to salvage treatment, second-line treatment, with either IV cyclosporin, infliximab, or tacrolimus. And if by day 7 the patient hasn't responded to second line, he goes for total colectomy, surgery. Okay? It might sound drastic, but this way you're going to save lives much more than harm them. Okay? Again, if the patient is steroid dependent, what do we do with him? He's dependent on steroids. Then treatment with thiopurine is an option, something like azathioprine. Treatment with anti-TNF, infliximab, adalimumab, or treatment with the newer drugs, the vedolizumab, the ustekinumab, or methotrexate. These are our gastroenterology guidelines, and they include methotrexate. Okay? Now, if this fails, we can shift the patient to a second-line therapy. If he has taken an anti-TNF, then you can give vedolizumab or ustekinumab, or one of the 3 drugs that I've shown you, the tofacitinib, the abdacitinib, or the ozanimod, the Zeposia. If that all doesn't work, colectomy. Okay, this is data for maintenance of remission, but I think we're already short on time, and I will finish here. Thank you very much.
Thank you, Professor Dr. Hisham. It was a very interesting end up for our meeting. And now we proceed to a short talk provided by Mina Farm. I introduce Dr. Mina on behalf of Mina Farm to give us a short talk about the Decaprino.
مساء الخير على حضراتكم. بيشرفنا جدا تواجدنا معاكم النهارده. وطبعا في البدايه I would like to thank our eminent professors. يعني احنا فعلا لينا الشرف اللي احنا موجودين في meeting in collaboration مع الرويال كوليدج. ويمكن انا هدخل على طول في الموضوع واتكلم على اولا مينا فارم مع حضراتكم. ليه بنتكلم عن مينا فارم؟ لان يمكن حضراتكم قريتوا في خلال الشهور اللي فاتت او سمعتم على اللي ازاي مينا فارم دلوقتي بقت من اهم الشركات في مصر والميدل ايست ونورث افريكا في مجال بس مش الفارماسيوتيكال برودكت العاديه، لكن في مجال البايوتكنولوجي. ويمكن كان في اناونسمنت لبروجكتس كتير تبع مينا فارم. مينا فارم هي جلوبال فارماسيوتيكال كومباني، ويمكن ده ممكن يكون على غريب على بعض من حضراتكم. هي ايجيبشن فارماسيوتيكال كومباني، بس احنا لينا 2 سبسيدريز منهم بايجن المانيا، جيرمان بيزد كومباني متخصصه في السيل بانك والتوريد الماميليان سيل والكالتشر سيل اللي بيتعمل منها بيولوجيكال برودكتس وورلد وايد. احنا يونيك استراتيجيك بزنس موديل موجود زي ما قلت لحضراتكم بدايه بمينا فارم اللي ليها اكتر من اكسبيرينس من 65 سنه بادويه كتير جدا في مجالات كتير حضراتكم بتشوفوها. ويمكن كمان احنا كان دايما في الادويه دي في استراتيجيك الاينس، دايما تلاقوا جنب لوجو مينا فارم انذر مالتي ناشونال كومباني، لان كنا واخدين ادويه كتير جدا اندر لايسنس، وستيل البرودكتس دي براندز حضراتكم بتعتمدوا عليها في المانجمنت بتاع بيشنت كتير جدا. وبعد كده جه في 2010 عملنا اكوزيشن لشركه بايجن المانيا، زي ما قلت لحضراتكم دي جيرمان بيزد كومباني متخصصه في الورلد ليد كونتراكت ديفلوبمنت ومانيفاكتشرنج اورجانيزيشن، متخصصه في السيل لاين عشان نقدر بقى كمينا فارم نصنع ادويه بايوتكنولوجي. يمكن اولها حضراتكم لو تفتكروا الانترفيرون المصري بجايليتد انترفيرون، بعد كده دخلنا في الريكومبننت، كان عندنا الريكومبننت تهريدين الثرومبكس والاكستروما، دخلنا في التكنولوجيا الاعلى من الماميليان سيل الريكومبننت اف سي اتش هرمون الجونا بيور. ودلوقتي ان شاء الله على بدايه السنه الجديده حضراتكم هتسمعوا على ريكومبننت تيرابيراتايد او باراثايرويد هرمون هينزل من مينا فارم. وستيل كمان في الاسامي الكتير اللي قالها دكتور هشام على الادويه البيولوجيكالز والانتي تي ان افس وغيرها، حضراتكم قريب جدا هتسمعوا مينا فارم بتسترايك البالانس ما بين الانوفيشن والافوردابيلتي، وهتقدم البرودكت دي باسعار افوردبل للايجيبشن ماركت ان شاء الله سون. اخيرا ميجنترا، وده النيو بورن بتاع مينا فارم اللي بيتمثل في مصنعنا المتخصص في البيولوجيكال المنفصل عن مصنع العادي، وكمان ليه سبسيدري في المانيا عشان ينقل البروسيس ويقدم البيست اوف 2 وولز. بعد المقدمة الطويلة دي احنا قدمنا قريب خلال 2-3 برضو الديكابرينو فيتامين دي 3 كل كالسيفرون 200,000 انترناشونال يونت. ويمكن كلامي اللي انا بتكلم على التكنولوجي ليه جايين دلوقتي كمينا فارم نقدم فيتامين دي 3 200,000 انترناشونال يونت، ده لان ستيل زي ما بندور دايما في الجاب او النيد في الماركت، ستيل احنا عندنا highest prevalence of vitamin D deficiency، عندنا patient كتير جدا بيبقوا محتاجين الهاي دوزز عشان نقدر نملى الستورز ونعمل زي ما بنقول لود تريت اند بروتكت البيشنت دول. واحنا بنتكلم مش على سبلمنت لان الماركت بقى مليان بسبلمنت كتير في الفيتامين دي، لكن ستيل محتاجين التريتمنت اوف فيتامين دي ديفيشنسي للبيشنت اللي محتاجين الهاي دوز. ومن هنا جه فكره الديكابرينو، وكعاده مينا فارم ده مش مي تو برودكت او جينيريك برودكت، ده براند برودكت احنا واخدينه من شركه اسمها دي اس ام، ودي سويس كومباني موجوده وورلد وايد، وهي من اهم الشركات المتخصصه على توريد المالتي فيتامينز والفيتامين دي وورلد وايد. حتى حضراتكم لو عملتوا سيرش عليها هتلاقوا اللي هي متخصصه في المجال ده. كمان الديكابرينو بتاعنا هو مختلف عن الاذر برودكت اللي موجود في الماركت، هو معمول بتكنولوجيا. حضراتكم هتلاقوا امبول الديكابرينو بتاعنا عباره عن 1 مللي امبول مش 2 مللي. طب ازاي 1 مللي في ال 200,000 انترناشونال يونت؟ لان هو محطوط الفيتامين دي على ميديم تشين ترايجليسرايدز مش بولي ايثايلين جلايكول، فبالتالي بيحسن الابزوربشن والبايو ترانسفورميشن بتاعه. وعشان كده حضراتكم هتلاقونا من دي 1 لما نزل الديكابرينو مكتوب على الباكج من بره وفي الانسرت ليفلت اللي هو كان بي تيكن انترا ماسكولار او كان بي تيكن اورالي، لان البايو افيلابيلتي بتاعته تسمح اللي هو بتستخدم كاورال، البيشنت يكسر الامبول ممكن ياخدها كلها يشربها على طول شرب، او يحطها على لبن وميه او المتعارف عليه. مفيش معموله بتكنولوجي مش اويلي اللي هو البيشنت يبقى فيه تيست او افتر تيست. يعني احنا يمكن حتى مع اساتذتنا البيدياتريكس، ويمكن بيشرفنا بروفيسور ايمن ايمين يعني يوافقني، البيشنت ممكن ياخد بسرنجه ديكابرينو ونحطها في بق الطفل زي ما بنديله اي دواء شرب. فبالتالي حضراتكم بتقدموا بريميوم كواليتي فيتامين دي ويز كمان حضراتكم محتاجينه مع بيشنت كتير. طبعا انا الاستاديز كتير جدا، انا هجو ثرو بس اللي حضراتكم متاكدين من البايو افيلابيلتي واللي هو بيشتغل within days ويملى الستورز up to 90 day، وده مهم جدا للبيشنت اللي عندهم فيتامين دي ديفيشنسي proven by studies اللي هو كان بي taken orally او كان بي taken intramuscularly. امبول واحد اوف ديكابرينو وده بروفن بستادي كانت بتقارن ما بين بيشنت بياخدوا 2000 انترناشونال لغايه 8000 انترناشونال يونت بير داي فيرسس 1 لودنج دوز 200,000 انترناشونال يونت، وكانت الريزلت كومبارابل ما بين ال1 امبول ديكابرينو والبيشنت يقعد ياخد ديلي تريتمنت. فبالتالي احنا بنقدم للبيشنت كومبلاينس وادهيرنس اللي هو يستيك للتريتمنت او ما يحصلش ميسنج للدوزز بتاعته. طبعا مع اساتذتنا في الجي اي تي والاي بي دي والكلام اللي احنا اتقال النهارده، انا طبعا مش هتكلم كتير، لكن احنا ادجوفنت تريتمنت لبيشنت محتاجين دايما بيكون عندهم فيتامين دي ديفيشنسي، وفي ريليشن بالريسنت ميتا اناليسيز، يمكن دي واحده من الريسنت ميتا اناليسيز على 18 راندمايزد كنترولد بلايند ستادي ومنشوره في 2020، وكانت بتتكلم عن الريليشن ما بين الاي بي دي وما بين الفيتامين دي ديفيشنسي، وازاي اهميه السبلمنتيشن المظبوط للبيشنت دول عشان يحميهم من كومبليكيشن كتير. واحده كمان من الريسنت داتا اللي في وان ستادي بيشنت عندهم كرونز ديزيز كانوا بيستخدموا كمان بيولوجيكال زي الانفليكسباب في الستادي دي، ولقوا لما ادينا 7 ويكس اوف هاي دوز فيتامين دي 200,000 انترناشونال يونت ده حسن الفيتامين دي ديفيشنسي اللي حاصل مع البيشنت دول، وصلنا للاوبجيكتيف بتاعنا اباف 30 نانو جرام بير ملي لتر، وفي نفس الوقت قللنا الانفلاماتوري ماركرز، لان زي ما معروف لاساتذتنا للفيتامين دي مهم جدا للانفلاميشن. وفي الاستادي دي الدوز كمان بتاعت الانفليكسماب اسكيليشن قلت كتير. بنتكلم على البيشنت الاوبيس والبيشنت اللي بيأندرجو بايرياتريك سيرجري، الاثنين محتاجين ديكابرينو او محتاجين فيتامين دي، لان افتر السيرجري بيبقى محتاجين سبلمنتيشن اوف هاي دوز من الفيتامين دي، واحنا السيفتي مارجن موجود في البيشنت اللي محتاج او السيفير ممكن نوصل كمان اب تو 600 انترناشونال يونت كوليكالسيفرول، يعني 3 امبولات ديكابرينو. ويمكن برضو البيشنت اللي محتاجين كده زي البيشنت اللي انا بنتكلم عنهم دلوقتي او الريكتس، الديكابرينو بيقدم كومبلاينس لان احنا 1 ملي امبول، فالدكتور حضرتك لو عايز تدي امبولتين مع بعض هيبقى سهل في 1 سيرنج 3 سم، فاحنا بنقدم كل الكومبلاينس اللي ممكن البيشنت يحتاجه. تو بريف اب او تو كونسوليديت كل الكلام اللي قلته، حضرتك بنقدم الديكابرينو اذا بيشنت كتير جدا في نيد للديكابرينو بريميوم انجريدينت، حضرتك عارف هو الاوريجين بتاعه جاي منين، ويز هاي كومبلاينس. كمان حضرتك بتبقى مطمن البيشنت ده الفيتامين دي بالنسبه له لمده طويله اشورد اللي هو اباف الليفل بتاعه، كومبلاينس بالنسبه للبيشنت لانه بيتاخد اورالي وبيتاخد انجكشن. واخيرا كوست افكتيفنس، الامبول بتاعت الديكابرينو 15 جنيه، فيمكن حضراتكم توافقوني، يعني ده يعني مفيش، حضراتكم بتشوفوا العجب، يعني انا ببقى مشفق على حضراتكم، انا يعني ولادي صغيرين ومراتي كل يوم ده سبلمنت من على النت ب 300 وب 500 وب 600، نفتح من ورا نلاقي 400 انترناشونال يونت فيتامين دي مع 20 كالسيوم مع 8. طب ده يقدم، احنا مش بنتكلم على سبلمنتيشن، احنا بنتكلم على تريتمنت اوف بيشنت اوف فيتامين دي ديفيشنسي. فبالتالي حضراتكم ب1 امبول اوف ديكابرينو هتقدروا تبقوا اشورد مع بيشنت كتير جدا اللي هم خدوا السبلمنت المظبوط من الفيتامين دي. هسيب الفلور لزميلي دكتور عادل يكلم حضراتكم على انذر براند السالوفالك.
على بال ما عادل يبدا البرزنتيشن بتاعته، انا بس كنت عايزه اقول 2 كومنتس مهمين جدا. البيشنتس وذ اي بي دي الريكومنديشنز بتاعتهم من ناحيتنا احنا كناس بنمانج الاوستيوماليشيا والاوستيوبروزس والحاجات دي، ما تدوش اورال فيتامين دي، ادوا انجكتبل، لان العين كده ولا كده الابزوربشن بتاعه بيبقى قليل جدا، فبريفيربل هم الانجكتبل فورمز. كان في تعليق على اللي قاله دكتور هشام بخصوص الماثوتريكسيت والتريتمنت. رجاء خاص لو هتدخلوا انتي تي ان اف من فضلكم ما توقفوش الاميران، ولا تشتغلوا بالانتي تي ان اف لوحده، هتدخلوا اميران يا ازاثايبرين عشان تطولوا عمر الانتي تي ان اف، لانه احنا كده ولا كده بيقصر عمر الانتي تي ان اف معانا. فدول من الحاجات الرجاء خاص من حضراتكم، دايما لما هتدخلوا انتي تي ان اف يا تحطوا اميران يا تحطوا ماثوتريكسيت، لانه ده بيطول عمر الانتي تي ان اف او البيولوجيك اللي عندك قبل ما البيشنت يعمل له انتي بوديز او يعمل له ديكلاين في الريسبونس. ثانك يو سو ماتش.
مساء الخير. First of all, I'd like to thank our dear chairman and professors and speakers for the very interesting and updated lectures. We were very interested to listen to you. أنا عادل هكلم حضراتكم على just one product، بس اسمحوا لي في الأول أخد من one slide على vision of Mina Farm innovation made affordable، يمكن استكمالا للكلام اللي سمعناه على الديكابرينو. كمان كل products of Mina Farm بتحمل نفس الطابع innovation and affordability. عشان كده Mina Farm is sticking to this motto عشان نقدم لحضراتكم فعلا innovative products all the time. One of these products هو السالوفالك. سالوفالك is a German product of Dr. Falk Germany under license of Salofalk of Dr. Falk لMina Farm. Salofalk achieving goal is your starting point. يمكن نتفق مع بعض انه ان انا احط للبيشنت جول من البدايه في التريتمنت اوف ulcerative colitis واجو ثرو الجول ده. one of the best measures اللي تخليني اعرف اكونترول الديزيز prevent الفلير ups and reach الريميشن especially a deep remission. That's what Salofalk is producing to you. لأن حضراتكم عارفين في حالات الالسرتيف كولايتس بتبقى عندنا الجي اي تي بيبقى فيه reduced ability to distinguish foreign from self antigen and reduced ability to downregulate the mucosa immune response. This makes a self-limited immune elimination process proceeds from the amplification phase to damage phase in which prostaglandin and many inflammatory mediators are produced. That's the role of Salofalk, to inhibit the production of prostaglandin, to trap the oxygen-free radicals and suppress the production of interleukins and all inflammatory mediators. The difference between Salofalk and other mesalazine present in the market is that it's a pH-controlled release tablet. السالوفالك زي ما حضراتكم شايفين فيه coating pH controlled mesalazine release provide high therapeutic levels at the terminal ileum and the enteric colon. يمكن مع بعض دلوقتي نشوف من خلال this short video هنا الالسرتيف كولايتس اللي انا ببقى عايز اشتغل عليه. سالوفالك mesalazine of دكتور فالك جيرماني بيدخل زي ما حضراتكم شايفين بالبي اتش ريليز كنترول لغايه ما يوصل للتيرمينال اليم ويبدا الريليز على بي اتش اكتر من 6 to reach high therapeutic levels at the terminal ileum and the entire colon for optimal efficacy. Unlike all other products موجوده في الماركت مفيش حد بيقدم the same technology زي ما قلت لحضراتكم. مينا فارم بتقدم حضراتكم innovation and affordability. The innovation here ان احنا بنوصل لغايه سايت اللي انا عايز البرودكت to be released فيه. هل ده عمل فرق ولا كل المسلازين زي بعض؟ حقيقي يمكن في 2017 في اليوروبيان كرونز اند كولايتس اورجانيزيشن ايكو 2017 كان في ترايل كانت بتكمبير الريليز اوف 5 ASA from mesalazine formulations كل الفورميوليشنز الموجوده في الماركت. and interestingly زي ما حضراتكم شايفين قال انه the time dependent release formulation البنتازا lost about 50% of 5 ASA in the small intestine and release only about 25% in cecum and colon, suggesting it's not enough to create a high concentration of mesalazine in the distal colon. وفي نفس الوقت بيذكر سالوفالك by name granules pH أكتر من 6 revealed an optimal dissolution profile corresponding to the physiological gastrointestinal pH gradient, supporting the effective therapeutic use of in ulcerative colitis, including patient with distal ulcerative colitis, ودي طبعا a very interesting and very hard case to be treated. So السالوفالك زي ما بقول لحضراتكم is a very strong product with German technology. كمان الداتا بتسبورت استخدامه زي ما بروفيسور هشام ذكر to combine التوبيكال ميثالازين مع الاورال ميثالازين to be more effective than any of the two choices alone. سالوفالك الدوزج بتبدا من 2 جرامز او more than 2 جرامز كمان بتوصل لغايه نقدر ندي لغايه 6 جرامز daily initially for treatment عشان اوصل للريميشن. ويمكن كان في ترايل اسمها مومنتم، يمكن كانت في فرصه كده حكيت مع بعض من حضراتكم قبل الميتنج على المومنتم ترايل اللي بتقول انه لما بدي دوز عاليه في الاول 4.8 جرامز at the beginning لمده شهرين بتساعد البيشنت انه يوصل للديب ريميشن. الديب ريميشن which means زي ما حضراتكم عارفين ان بيبقى الميوكوزا هيلد تماما. وبعد 2 months ابتدى الترايل لمده سنه كامله بعد كده على 2.4 جرامز، وكانت الريزلتس فعلا بتسبورت الايفيدنس انه لما ابتدي بهاي دوز بحصل على الديب ريميشن، والناس اللي وصلت للديب ريميشن استمرت عليها خلال سنه كامله بعد استخدام الهاي دوز اوف سالوفالك. Salofalk, our place is reserved مع حضراتكم high therapeutic levels at terminal ileum. Salofalk is a tailored mechanism of action against pathogenesis of inflammatory process with excellent tolerability and long-term therapy. بشكر حضراتكم. كمان بذكر بالأورسوفالك أورس دي أوكسيكوليك أسيد برضو من شركة دكتور فالك في كل حالات البيلياري ريفلاكس ديزيز. Okay, 2 products but just to mention الأورسوفالك plus السالوفالك. أخيرا بشكر حضراتكم. بقول عندنا في البروجرام ما بين حضراتكم او لو عايزين دلوقتي على طول سكان الكيو ار كود ده عشان في يمكن برضو دكتور ريم هتقول
يعني this is a QR code for a survey about your satisfaction with the meeting, and it's also very important to fill it up to have your data and provide you with the certificates from our side. So kindly either scan the QR code and go now online, or you can just display the survey. Okay.
موجود في البروجرام كمان.
It's there in the program. You can use it now just to provide opinion and how do you rate our meeting? Are you satisfied or not? And we are also welcoming any further suggestions or on our email. We have an email, and I think Mina Farm can provide it for everyone so that we can communicate for further meetings. Suggestions for workshop held up by the Royal College of Physicians are more than welcome from your side, and it's our pleasure to host you. We hope you are satisfied with our meeting. Thank you so much. في بس سؤال كان سؤال صغنن جدا، انه ليه توكسيك ميجا كولون مع الاندوسكوبي في العيانين سيفير كولايتس؟ ده كان سؤال من الاودينس لدكتور هشام. يس دكتور عمر كان بيسال السؤال ده واحنا للاسف يعني قلنا له استنى، فهستاذنكم نجاوب بس السؤال ده. دكتور هشام.
هي بس فكرتها نفس فكرة الكولونوسكوبي. If you stretch an inflamed bowel, it may never function again. مع الباول بريبس دي انت بتزود الفوليوم، لانها نان ابزوربل بولي ايثيلين جلايكول بيشد معاه ميه ويكبر جدا في الحجم. اوكي، فهي ميكانيكال فاكتور.
حضراتكم برضو لو حابين تتفرجوا على الميتنج كله بالكامل موجود على live.minafarm.com، ويمكن حضراتكم ممكن تشوفوا ميتنجز تانية عملناها قبل كده، واللينك ده مكتوب برضو في البروجرام اللي مع حضراتكم. يعني كل اللي حصل النهارده موجود ومتسجل على اللينك ده، ممكن حضراتكم تشوفوه في اي وقت او ترجعوا له في اي وقت. نورتونا وشرفتونا، بنشكر اساتذتنا جدا وميرسي جدا لحضراتكم. شكرا.